Good afternoon. Medications affecting the endocrine system. Welcome. We're going to start out for the endocrine system with diabetes mellitus. We're going to start out with insulin, oral anti-diabetics, non-insulin injectables, and of course, hyperglycemic agents and hypoglycemic agents. These are the four categories of insulin that you need to know. Okay? Rapid, short, intermediate, and long. And before you even begin to start to try to process what these insulins do, you need to understand that they are set up to mimic exactly what your pancreas is doing for you right now. My guess is you have something near your desk, a coffee, maybe a Mountain Dew that you're drinking for the afternoon, maybe an iced tea. And every time you take a sip of Mountain Dew, your pancreas releases a little bit of insulin to deal with that extra blood sugar. That extra insulin brings your blood sugar back down to normal. And you'll go and you'll have a meal tonight around supper time, and that you'll eat that meal, and the same thing will happen. Your body will release a little insulin to deal with that meal. Well, your body also releases insulin all day long in a long-acting sense, so it can maintain homeostasis. So your body releases rapid insulin for you, and it also releases long-acting insulin for you to maintain your body throughout the day. Well, now we go to somebody who's got diabetes. A type 1 diabetic doesn't make any insulin at all. Type 1 diabetes is often called juvenile diabetes. It tends to happen in people under the age of 30, but not always. They actually say now, or they are able to say now, that type 1 diabetic has had a virus attack their islet cells, which make insulin, and it entirely wipes out their insulin production ability. So they need to cover both before their meals, and they also need probably a long-acting insulin. All right, that's something that you'll see people on more than one type of insulin. Okay, sometimes you might see someone on no insulin, a diabetic, but for now we're going to talk about these. So you see this type 1 diabetic, he's on the rapid, or he might be on the long, or he might be on the short and the long. It depends on the patient. It's always specific to that patient. So we're going to talk about the type 2 diabetic. He may or may not be on insulin, and he may or may not be on one or more. But if you start out on the left, these insulins are set up to mimic the pancreas. So we have the rapid acting insulin. The main names to know are Lispro, Aspart, and glucosine, and those brand names are Novolog, Humalog, and Apidra. When you see that N in that Novolog is made by Novo Nordisk, and they start all their insulins with an N, and Eli Lilly makes Humalog, and they start all those with HUM, Humulin or Humalog. All their insulins start with that. Okay, so if you go here, the big thing on this rapid-acting insulin, and most students don't miss this when I question them, they don't miss it on ATI, is rapid-acting insulin is rapid. That's the insulin that we give people before they eat their meal. And most nurses, I've not met a nurse who won't wait until the food is right in front of the patient until they give this insulin. Because I'm always worried that the kitchen got behind and they don't have the tray in their hand, and I'm not going to go in there and give this insulin and wait 45 minutes for the tray to come from the kitchen and then have this patient on the floor with hypoglycemia. So this onset of 15 to 30 minutes, I take that very, very seriously, and you should too. Think about that. It means you kind of have to give the insulin right when you see the meal come. It does require some time management from you as a nurse, but it is absolutely about the only way that you can handle rapid-acting insulin. It has a peak of half an hour to 2.5 hours, duration 3 to 6 hours. They also make a short-acting insulin that onsets in 30 minutes to 1 hour. And short-acting insulin is also called regular insulin. And they don't have they just call regular insulin Novulin R and Humulin R. They actually have the onset in half an hour to an hour, and they peak within an hour. I do see sometimes these two, I have seen short-acting insulin used before a meal, depending on the patient. It's something to kind of keep in mind. If you go over on the right, there is an old school long-acting insulin. By old school, I mean it was the only long-acting insulin that we had out for a very long time. It's called NPH. And NPH is very characteristic that it's cloudy. When you look at it, it's a suspension. It has like little particles in it, and you have to roll it to activate it. It actually has an onset of 1 to 2 hours. It peaks in 6 to 14 hours. I would probably commit those to memory. They tend to ask you odd. You see, well, a lot of people don't take NPH. Well, that's not necessarily true anymore. Walmart is selling NPH at a discounted price for dealing to help people afford their insulin. They now have you can buy NPH for $24 a bottle. So we're starting to see people on NPH, and I'm starting to see a lot of ATI and stall questions coming up asking about it. The last insulin on here, I've given you one example of long-acting insulin. There are several. Insulin glargine. It goes by the name. There's some names. You'll see the word L a lot of times. Levemir and Lantus in the long-acting insulins, and they're very unique in the fact that they don't have a peak. We often give them. We give like a lot of people take it in the evening before bed. I've seen a lot of people take it in the morning. I've also seen people whose diabetes is hard to get under control take this insulin twice a day. There actually is a category of non-insulin injectable medications. They're called Cretin Mimics. And so, well, what are Cretin Mimics? They're agents that act like the incretin hormone, one particular called glucagon GLP-1. And it goes down, this medication goes down and binds to the receptors for GLP-1, and it stimulates glucose-dependent insulin release, and that makes it an anti-hyperglycemic. This also is very good at suppressing appetite. It inhibits glucagon secretion. These are injectable. They're usually given like once a week or sometimes once a month. You see a lot of commercials for especially this Ozempic. My family goes around saying, oh, Ozempic. It's a medication that's very heavily being advertised on the television because we have so many people with type 2 diabetes in the United States, and they have a hard time getting their diabetes under control. You may start to see these if you do your ATI. When you do your ATI diabetes module, you're going to see them reference this group of medications. I suppose you are wondering why I have a nice KitchenAid mixer in this presentation. You can sort of debate why I might have put that on there, but what I wanted to talk about was if I take a long-acting insulin and then I am prescribed a rapid-acting insulin, can I put those in the same syringe? Why or why not? And the rule, sometimes how I talk to you guys, there are unbreakable rules, and the rules are the same whether you move to California or Russia or Japan or Alabama. Well, a rule that we have that you can't break is that they do not mix insulins in the same syringe. If I am taking a Pedra, a rapid-acting insulin, and I also need an injection of Lantus, which is a long-acting insulin, you must put those in 2 different syringes and put those in 2 different injection sites. There are 2 insulins that can be mixed if necessary. It's NPH, the cloudy, old-school long-acting insulin, and R. Either novel NR or human NR can be mixed in the same syringe, and that's where we sometimes teach you in lab to mix clear to cloudy. Most people now don't even try to mix those. It's really difficult to mix for an older person to have to go through the rules to remember the clear to cloudy. But as a nurse, they do expect you to know that and to know that those 2 could be mixed if it was necessary. I want to talk a little bit about sliding scale insulin. Sometimes, particularly if you have a patient coming to a hospital setting and they're very, very sick, their blood sugar will be all over the place. It may be high one day, it may be low a little bit later. It's all over the place, so they'll write something called a sliding scale. And if you look on the left here, it says a standard sliding scale insulin protocol for a patient with diabetes mellitus. And if you go down the scale, it says if the blood glucose is 61 to 150, 0 units of insulin. If the blood glucose is 151 to 200, give 3 units of insulin, and so forth. It goes down. If your blood sugar is 245, you're going to give 5 units of insulin. Sliding scale is usually done with a rapid-acting insulin or the short-acting insulin. It can also be, they can use this sliding scale for someone who is not necessarily a diabetic. Sometimes a person will come in and all of a sudden they're just deathly sick. They've been septic and they were down in the ICU, and now they're talking about going to the rehab hospital, and they noted on the lab work that the person was running a little bit of an elevated blood sugar. It doesn't mean that they are diabetic. It means that the body releases extra sugar when it is under stress. So you may sometimes go in to use this sliding scale on a patient who doesn't think they're diabetic, and when you go in with insulin, I've had them go, wait, what? I'm not diabetic, and I had to do some teaching with them and say, well, now listen, you're right, you're not a diabetic, but your body's responding with some extra some extra glucose today, and we're giving you a little bit of insulin to help you with that, to help you try to so you can try to get better quicker. And usually most people are okay with that. I see this sliding scale a lot at the nursing home where I used to be with students, and we had a lot of people in their 90s, and they would go over on Friday and they would get a donut. And the order would say, on Fridays, if this patient would go over and she eats a donut, go ahead and get a blood sugar, and here's the sliding scale if she has a donut. The patient was 95 years old. I think the thought was that we're not going to tell her she can't have a donut. She's 95 years old. We would just cover it with a little bit of insulin. She actually did not take insulin the rest of the week, but she is a good person for a sliding scale. This scale on the left is the most common you see. I'm actually sharing with you the scale on the right. I'm a little bit familiar with it. You may start to see this scale in your practice, but they do have some people who end up being a little bit resistant to insulin. And the person that I am familiar with the scale with is actually a family member. He's had diabetes for quite some time, and he's a little bit insulin resistant. He's gotten to where maybe most people would take 4 units if they were 235. He needs 6 units. So if you do have someone who has type 1 diabetes, you may see a scale that looks a little more like the one on the right. You'll know which one they want you to use. They either want you to use the left, highly insulin sensitive column, the middle, normal insulin sensitivity, or the third one, highly insulin resistant. And most patients who've had diabetes for a long time can tell you if they're taking insulin, if they're on the what they call a normal sensitivity, or they're on a little bit higher sensitivity. The insulin pumps actually have that ability now to program them for that type of administration of insulin. I would recommend that everyone go in and do their ATI module on diabetes mellitus. It's actually under the skills module. It's very, very helpful. It talks about how different patients have different treatment and different amounts of insulin, different types, and different times during the day that they take it, and how that is individualized for the person. It talks about therapeutic uses of insulin, which we have also talked about here. And then it talks a lot about complications in patient teaching. One of the complications that it talks about is called lipohypertrophy. That lipohypertrophy is when the subcutaneous tissue, when you continually put the same insulin into the same location in the subcutaneous tissue, it'll get very, very hard. Lipohypertrophy. Hypertrophy means it's going to get real hard and start to it won't absorb insulin anymore. So we teach people to rotate their insulin injection sites. They used to teach that you would, and you make note of this technicality, they used to have you rotate your sites. You would do left arm, left leg, right leg, abdomen. Now they have you do your abdomen. They have you do like 3 locations, so many locations on the abdomen, and then move to the arm, and then move to the other arm. So that's something that's changed, and that can trip up people, especially when you're having to take computerized testing. We talk about storage of insulin. It's normally stored in the refrigerator, but people take it out. They need to keep it cool if they're traveling. It can be out of the refrigerator for normal time is 30 days. There are some newer insulins that say you can go up to 45 days before you have to throw the insulin actually away. Is something to keep in mind. Interactions is always a big topic that you need to comprehend. And the drug here that we're going to talk about is steroids, or prednisone. And what is prednisone? Well, it's an anti-inflammatory. It comes up in the anti-inflammatory chapter. It comes up in the pain chapter. It comes up in the respiratory chapter, because prednisone can be given for pneumonia, respiratory problems, for asthma. It can be given for pain and discomfort. I've seen it given for other similar reasons, but it does one key thing. Actually, it does 2. It actually raises your blood sugar, whether or not you are diabetic, and it actually lowers your calcium level. So in this situation, for an endocrine discussion, if you have a diabetic person and they have to take prednisone, then they are going to have an elevated blood sugar that we are going to have to adjust with more insulin for them, more blood sugar checks and more insulin for them to take. So it's something to think about. And then everything that we've talked about here has just enormous nursing implications. If the patient doesn't know what's going on, how to administer his insulin, or what to expect, then he seriously is going to not be as healthy as he can be. Treatment of hypoglycemia. For those of you who have not been around someone who was hypoglycemic, they'll start trembling, sweating, they sometimes their voice will change. They feel like they're going to pass out, like the room is spinning. And there's some general rules to follow. And keep in mind that for hypoglycemia, that some patients are very symptomatic when their blood sugar is 70. Keep in mind the blood sugar falls very quickly. It may be 70 at 205, and by 210, it's dropped to 35 for a patient. It drops very, very quickly, and they can go and they can seize and they can die. So if a patient is able to talk and speak, what should the treatment be for hypoglycemia? If a patient can talk to me, regardless of what the blood sugar is, if it's 70 or 20, as long as they're talking to me, I'm going to give them something that they can consume, preferably something that's sugary. Orange juice, milk works well, grapes, raisins, anything like that in that range. A lot of people do carry what they call glucose tablets. I have found they're not as effective as perhaps something like taking a bottle of frosting and squeezing it under someone's tongue. But most people carry something to help themselves when they are hypoglycemic, and most people know when they're becoming hypoglycemic. The one on the question on the right brings up something totally different. If the patient is unresponsive and you suspect hypoglycemia, what treatment will be initiated? Well, one of two things. You're either going to put an IV in the patient and inject what's called dextrose 50%. Usually it comes in a bottle in your emergency cart, and you push it over about less than a minute, and that usually is enough to have a patient awaken and respond to you. And then you would need to want to give that patient something to maintain that blood sugar up, something with a little bit of protein in it. But if the other thing that you would do would be to give the patient have a glucagon pen, and a glucagon pen is like an EpiPen. You pull it out and you have a powder that you push down with the liquid, and you kind of shake it and you just jam it right into their thigh. I don't even take clothes off if I ever have had to do that. You put it right in their thigh and you inject it. And that glucagon, if you remember back to pathophys, that's going to initiate some glucose and bring that glucose level up. For oral anti-diabetic agents, we're going to talk about metformin and glipozide. They are the two most common oral anti-diabetic agents that people usually start out on when they are first diagnosed with diabetes. Metformin also goes by the name glucophage. Metformin actually helps you to use the sugar more effectively that is in your body. It does not cause you to release more insulin. Okay, and if you take metformin, it has a notorious side effect that causes terrible GI upset. It will cause you to get, when you first take it, the first couple of weeks, people get a lot of diarrhea complaints, because basically what it's doing is pulling everything out in your colon and putting it out through that way. It doesn't really have a risk of hypoglycemia with it. It does have a couple issues though, because metformin is excreted through your kidneys. You have to watch and take care of your kidneys while you're on it. If the first thing would be if you're going to go for a CAT scan, and anytime you ever have a patient that is going to go for a CAT scan and they're going to get contrast, the staff member in CAT scan will ask to speak with you, and when you get on the phone, they go, is this person on metformin? And if you say yes, you have to hold the metformin for 48 hours before they can give you the CAT scan dye, because we don't want to shut down a person's kidneys. The other thing, you have to check their BUN level, because we want to make sure that their kidney function is acceptable. And we don't encourage people to take NSAIDs, because they are also hard on your kidneys. We discourage alcohol when they're taking glucophage. Alcohol is actually, of course, excreted in your liver, but we don't want to do any more thing to do any damage to those kidneys. There should be some, because of these issues that I just mentioned, there definitely is some nursing education associated here with this medication. The medication glipozide comes from a class of medications called sulfonylurea. They are a sulfa base, so if someone has a sulfa allergy, they cannot take this medication. But this medication will encourage someone to produce more insulin to deal with their elevated blood sugar. A lot of the same side effects that you have to watch for with the other medications. Watch for hypoglycemia, avoid during pregnancy, and these folks all have to still maintain their diet and exercise. These pills aren't going to allow them just to eat what they want. And a lot of times you see that with patients. They go, I just want to take a pill. I don't want to have to watch what I eat. We really, really need to talk to people about watching what they eat. I have included this chart here, oral anti-diabetic medications. There's actually, because diabetes is at so many people are being diagnosed with type 2 diabetes in the United States, pharmaceutical companies have come out with some different classes of medication over the last several years. Predominantly here, ones that I will mention to you. We talked about the first two categories. I'm going to go down and talk about the two categories on the bottom. One is called DPP-4 inhibitors, and that includes the drug Januvia. And Januvia is very commonly prescribed. It actually increases insulin and decreases your glucagon production. And the SGLT2 inhibitors, and you've probably heard of Jardiance. And Jardiance prevents your kidneys from reabsorbing sugar back into your blood and puts it out through your urine. Those are very, very common. I've also seen the drug on here, Actos. Actos on here is the drug that I have seen where a lot of people say that it gave them cancer, but it is actually still on the market. There was an increased risk of heart failure with it, but because of the way we do our medications here in the United States, you still see some of these medications that are giving people trouble. But I know the first thing that I hear on people is, what's on the test, Miss Weibel? I'm going to go simple, go basics on your test, but you need to understand that these other medications are becoming more and more common, and you may be giving them as in your nursing career. I want to talk a little bit about the thyroid. I don't know if you remember, but the thyroid's main job is the master regulation of your metabolism. Your thyroid's in the front of your neck. It's around your larynx and your trachea. It actually looks like a butterfly. It makes two hormones, T4 and T3. It does that by using iodine that you have in your blood. We have to have iodine. Usually salt has iodine in it, or when you buy Morton salt in the grocery store. Thyroid cells are actually the only cells that actually absorb iodine in your body. And you need to remember that every cell in the human body relies on T3 and T4 to manage metabolism. And if you look here, symptoms of hypothyroidism, that makes sense here when you look at this. What are your symptoms of hypothyroidism? Weight gain, poor memory, being cold, feeling tired, slow heartbeat. You can actually go into a coma because you have you can actually slow your heart down to almost nothing. Your hypothyroidism can put you into a coma state. We have a medication to replace T3 and T4. It's called levothyroxine or Synthroid. The therapeutic use is to give to someone who no longer has a thyroid function. A lot of times people get goiters, especially here in Ohio. We live along a goiter belt because we don't have any iodine in our water. Very, very common to be on that medication. It's in micrograms usually. It's such a common medication that it's the same color all over the world. If you're like 224 micrograms, it's pink all over the world. It's because it's given everywhere. It's one of those considered a medication that we need everywhere. If you go here, this Synthroid, when you go to do your drug card, has some particular rules. They recommend that you take it in the morning on an empty stomach, at least an hour before meals. They also need to talk to patients and do patient teaching with patients and make sure that they understand that they have to come in for regular blood work to monitor their T3 and their T4 level to make sure that they don't get too high of a dose of this levothyroxine, because if they do, they could have cardiac symptoms. So you take this person, they have hypothyroidism, we start them on levothyroxine, the dose is a little high, they're no longer going to have signs of hypothyroidism, they're going to have signs of hyperthyroidism. So that's something that students always struggle with. They always miss test questions on that to understand the connection there. Thionamides, the main drug that you need to know in this particular class is this drug called methimazole, and it goes by the trade name of Tapazole. And the way I always remember this is I tap my thyroid to remember what this drug does. It stops the T3 and the T4 that your thyroid is making for someone who is in a hyperthyroid state. Methimazole prevents the thyroid gland from producing too much of the T3 and T4, and is predominantly used. It's for overactive thyroid. It can be used before thyroid surgery also. It is a tablet. It doesn't come in any other form. My understanding is it's up to 3 times a day you take it, and with food. There are some precautions that they talk about. If you're allergic, of course, apparently lactose. If you're lactose intolerant, you can't take it. As obviously warfarin and Coumadin, you are not supposed to take that with this medication. This medication is excreted through your liver, so if you have poor liver function, it is not a medication you can take. And you need to keep in mind the most important thing. Just like with hypothyroidism, a patient who is taking something to stop T3 and T4 is going to need to go in and have their T3 and their T4 measured, probably for the rest of their life, because if you have hyperthyroidism and you take Tapazole to decrease your T3 and your T4 from your thyroid, there is a risk that you will become hypothyroid. So that means that you need to understand both the signs and symptoms of both of those, because someone having a thyroid problem being treated can go back and forth either way between either one. If you have hypothyroidism, you can take too much medicine and have hyperthyroid symptoms. If you are in this situation here and you are a hyperthyroid patient and you take this medicine, you can become have signs and symptoms of being hypothyroid. I want to talk about radioactive iodine. If you think about this, what you know, there's a little bit where med-surg and pathophys are going to overlap here for endocrine. Your thyroid gland absorbs all the iodine in your body. And because of this, they use radioactive iodine. It's also called, I-131. They use that I-131, that radioactive iodine, to treat thyroid cancer. They call it RAI for short. The RAI collects mainly in your thyroid cells, where the radiation distorts the thyroid gland and any other cells, including cancer cells. And this is if you would have thyroid cancer. And this doesn't, and luckily, it doesn't affect the rest of your body. The radiation dose that they use to destroy your thyroid is a little stronger than the radioactivity they use in some of the thyroid scans. So they use this treatment to ablate or destroy the thyroid tissue that they can't remove from surgery, or to treat some types of thyroid cancer that look like they have spread to lymph nodes. They have some patient teaching. If you think about this, if you give somebody radioactive iodine, they need to sleep at home in a separate bed 6 feet away from other adults for, I believe it says though, 1 to 11 days. They're supposed to delay their return to work and stay away from children and pregnant women. They will put them in a separate room when they come into a facility. They normally have them flush the toilet 2 times to try to get rid of their radioactive urine. So there's a lot of education involved with this particular treatment for thyroid cancer. As you have probably figured out at this point, some people do have an iodine deficiency. They can actually be given iodine to take. It's sodium iodine. Very few complications. The iodine is mostly used by your thyroid. But obviously, we do need to educate people. They need ionized salt. They probably need repeat lab work if they're having electrolyte problems and need this iodine level monitored. Anterior pituitary hormones, somatotropin. Somatotropin is growth hormone. A growth hormone. Somatotropin is a form of human growth hormone. It is very important for the growth of bones and muscles. It is given to treat growth failure in children and adults who lack the natural growth hormone. This can be someone who is particularly short. I believe the term when I was young, they say little person now, but sometimes people they just don't grow. There are other causes of short stature. It's normally this medication is injected into a muscle or just under the skin. We do sometimes have to teach people how to do their own injections. The one thing that you want to keep in mind here, though, is that this particular medication affects affects how insulin works in your body. So it can make you hyperglycemic. Therefore, if you would also be taking the drug prednisone, which we also know raises your blood sugar, you would be at terrible risk for hyperglycemia. We also know that if this medication is given to someone who is a child who hasn't reached their full growth, it can affect the growth of their kidneys. So we worry about that. So those are all important nursing implications for this medication. We're going to talk about diabetes insipidus. Diabetes insipidus is not diabetes mellitus. Okay? What happens is a person has particularly a person who's had a head injury, or they've had a pituitary tumor, a craniotomy, as you can see here in our lovely picture. Something happens in the pituitary and the antidiuretic hormone is no longer being stored or monitored or regulated by the pituitary gland. And so therefore the kidneys are pumping out urine in a huge, at large quantities, and the patient is drinking large quantities of water. Right? They can have signs and symptoms, 20 liters output of urine a day. Think about what a 2-liter bottle looks like. And you can think that that's a lot. The specific gravity of the urine goes down. That means it's watered down. Osmolality goes down. The patient can become hypovolemic. They're very thirsty. Tachycardic, blood pressure goes down. So your nursing care comes in. You have to monitor the fluids, replace the fluids. You're going to be checking vital signs, mucous membranes, and you're also going to be giving, we can also give antidiuretic hormone. It is known by the name vasopressin. Vasopressin is one form, and where it says DDAVP, that stands for desmopressin, and that is like a synthetic form of antidiuretic hormone. We're going to go and we are going to replace this medication that they are missing, and they are going to probably need this medication for the rest of their lives, and they are going to need these things that you see here, these signs and symptoms monitored. Adrenal hormone replacement, cortisol. Cortisol is a normal hormone produced in the outer portion of the adrenal glands, and when it is functioning correctly, it helps the body respond to stress and change. It ends up mobilizing your nutrients. It modifies your response to inflammation. It makes your liver raise your blood sugar. It helps control the amount of water in your body. Cortisol actually is regulated by your pituitary gland up in your brain. But the problem happens if you go and you take cortisol for a long time. If you have a high exposure to high cortisol levels for a long time, you either get Cushing's syndrome or Cushing's disease. The most common cause of Cushing's is the use of the steroid drugs. It can also signs of Cushing's: a fatty hump between the shoulders, a rounded moon face, pink or purple stretch marks on the body, menstrual irregularities, blurred vision, severe depression, easily fatigued, the high blood sugar, signs of osteoporosis, all problems from taking hydrocortisone or prednisone for a long length of time. We already know that taking prednisone causes hyperglycemia. I mean, when I say it causes hyperglycemia, I mean people can have a blood sugar of 600 on the meter and they haven't even eaten anything. It's just pure sugar. This can cause calcium depletion and osteoporosis. If this drug is taken on an empty stomach, it will eat up your stomach and cause a bleeding ulcer. It also causes signs of possible increases infection risk from wounds. Wounds are slow to heal. It's just there's a lot of patient education with this particular medication. If you take it for a short term, they'll give you a little pack. They call it. I have six prednisone to take the first day, 5 the second, and so forth. It'll go 5, 4, 3, 2, 1, and you have to do a lot of patient teaching with a patient who's taking those little blister packs, because we have to make sure that they take all of that medication. Hyperpituitary medications. There is one drug listed here, Octreotide. It is used for someone who has too much growth hormone. It's actually synthetic. It lowers excess growth hormone in someone who is an acromegalic giant. This drug also can treat diarrhea that is associated with certain tumors. It's given sub-Q or IM, and you need to do a really good head-to-toe assessment on someone on this medication because it can cause a slowed heart rate. And if you look in the picture here, an acromegalic giant, there are people that are they have an issue where they make too much growth hormone. If you can make you grow very, very tall, and once your bones seal shut, then you can still have that growth hormone come out, and that's called acromegaly. I have not seen this medication given a lot. I actually have seen it given more for control of GI symptoms with cancer.